what exactly CBAHI is, and we make you an expert in almost all aspects of CBAHI. And today, so Anexas conducts a lot of training programs, as all of you know. We have got Lean Six Sigma, CPHQ, quality-related programs, and anything to do with quality. We generally have it in our menu card. And I'm proud to say that Dr. Radwan had been, he has attended and got certified from Anexas in different certifications. In fact, I would be happy to, maybe Dr. Radwan can talk about himself more, but I'll just introduce you to him. And he is currently based in Saudi Arabia with 20 years of experience in the field of healthcare and 15 years of experience in the field of healthcare management. And he has been a CPHQ since 2010. And he has got excellent interest in quality, and it is shown that by his interests with our training programs. So today he's going to talk about CBAHI, and I'll just allow doctor to talk. After a brief, talk by maybe 2, 3, 4 minutes of talk by Dr. Radwan, I will have a poll. So once a little bit more people join in, I'll conduct a poll, means in the sense I'll ask some questions, and that will take around 2 to 3 minutes. And after that, we'll start learning. So yes, Dr. Radwan, some opening lines from you.
Yes. First of all, it's I'm very proud and very happy just to be introduced by doctor. Maybe 2 or 3 years ago, I was one of your students. I am proud that I took Lean Six Sigma green belt and black belt with Anexas, and by you and by your amazing team. So this is just to mention in the start. Generally, by background, I'm a physician. I am graduated from Egypt, and I started my work there in Egypt. Then I started my journey in quality, I think, in 2008. My postgraduate diploma from American University in Cairo. Then I moved to join Saudi German Hospital Group. It was in Riyadh for more than 5 years. I started in quality, and I left there as assistant chief medical director for the hospital. During this time, of course, we are with all the requirements. During this journey, I finished my master in business administration, specialty in quality management from Leicester University. My master in international public health also from Liverpool University, and CPHQ Lean Six Sigma. So the journey is very long in the field of quality management, and I think it's very important for us. I'm speaking about healthcare to run in the journey of quality management, at least to be like other fields who are, I think, more advanced compared to us in this area. They were able to integrate the quality features in the DNA of their fields. Still, in quality in healthcare, we are facing some challenges related that many healthcare professionals, nurses, physicians, because they have no experience, they are not educated in quality, so they are considering this as a foreign body in the industry. We have this resistance. I think by accreditation, by training, by orientation, day after day, we are gaining new land in the field of quality management in healthcare. So I hope the orientation session today will help our colleagues to understand, like an overview for CBAHI and its main structure and requirements in general.
So great, great, Dr. Radwan, and again, always a pleasure to talk to you, and good to see that right now today you are here as a presenter. So that's something we are proud of. Okay, so
my honor.
So I had seen you as a student once. Now you are as a presenter, and that's what we always say. All our say participants or people who participate in our training programs, we want to make them a presenter, a trainer, consultant, and we want to give everyone a good platform. So on that note, let me ask one question. Are you a healthcare professional? That's a basic question I'm asking everyone. So there's a poll, and if you can answer, so because we want to just make sure the people who are attending are from healthcare, and if not, then we'll also get a context. So every 100% of the people are from healthcare. So that's great. That's great. And thanks for telling us that. And we expected that maybe one person is not, one or two, like so few people are not from healthcare, but we will be, as as you would know soon, this accreditation, CBAHI, which we are talking about, belongs to healthcare and for hospitals, clinics, etc. And this is especially for Saudi Arabia. So just wanted to inform you, inform everyone about it. Okay, now let me ask another question, and this is the second question, and after that we'll start our session. Are you a part of CBAHI accreditation process in your hospital? So a hospital or a clinic or lab, are you part of CBAHI accreditation process? So I see around 56% are not part of it. So in this case, yeah, so around 60% are not part of it. So that's you will see a lot of value addition. This is more of introductory program, but of course we'll go into the detail. Dr. Radwan is going to talk about details as well. So yes, so as I said, 71% of the people now, and people will join in as happens. Like that is why I was talking about general things, because people join after 5-10 minutes after we start the training session. So thanks a lot for participating in the poll. And okay, great. Now let us start the session. And yes, Dr. Radwan, so the floor is yours.
Just before starting the session, I just have a very simple clarification. As long as you are working in a healthcare organization in Saudi Arabia, you are part from CBAHI process, because CBAHI is not a healthcare accreditation focusing only on the physician or the clinical care or the nursing care. It is looking to the organization as a complete organization. We have a lot of chapters related to the patient care areas, and we have also a lot of chapters related to the administrative, the leadership. So either you are working in HR, working in internal medicine department, in ER, in inventory, in supply chain, you will be part from the process. This is just to clarify for everyone attending with us. So can I share my presentation now? Can I share my screen?
Yes. So you can share your screen. And now I see some more people have joined in, and as people will keep joining in, welcome to everyone who has joined recently. And
okay.
So we have just who joined recently, we have Dr. Mahmood Abdul Fattah Radwan presenting about CBAHI accreditation. And yes.
Okay, so
we can see this.
Any...
We can see the screen. It's full screen. It's perfectly fine.
Okay, so we can. So just in quick review, in the start, we are trying to differentiate between, for healthcare, I mean, what is license, what we mean by license, and what we mean by accreditation. Usually, the license is the mandatory requirement. It is usually imposed by the government itself, regardless of the country, and it is presenting the legal right to provide care. As a hospital, you are licensed to provide care. It is controlled by laws, by regulations, and it is usually issued by the legislative authorities in the country, and it is focusing on the minimum requirements you need to provide to your patients or to your customers. Accreditation on the other side, usually it is voluntary. Usually, I am speaking usually because we have exceptions, and usually the accrediting body is an independent organization. It is not directly belonging to the government, and it is reflecting the optimum standards of care and the quality of care provided to your customers. And usually the requirements is written in the form of standards you should comply to, and these standards are usually written by experts in the field of the industry of this accreditation. So why we said usually voluntary? Because in some countries they are making the accreditation even obligatory, and CBAHI is one of these examples. In the start of the journey, CBAHI was voluntary. Any hospital can join or cannot join the program. It's up to your decision as a hospital. But after this, they imposed CBAHI to be done by everyone, and they linked this to the license. Whenever you are going to take your license or renew your license, you need to have, one of the requirements is to have the CBAHI accreditation. So this is one of the features for CBAHI. Also, for us in healthcare, we have usually we are dividing the accreditations into two main categories by accrediting body, is either to be an international, which means it is global, like GCI, like Canada accreditation, like Australian accreditation. Although these accreditation bodies are located in USA or Canada or Australia, but they are going to do accreditation for hospitals all over the world, in Asia, in Europe, in Africa. And on the other side, we have accreditation bodies which are national, located in a certain country, and they are focusing on healthcare organizations in this country. And we have here CBAHI, of course, in Saudi Arabia, and we have GAHAR in Egypt, for example. And I think many countries, they have their own national accreditation bodies. On the other side, we are dividing also accreditations, types of accreditation through another classification. Here we are looking to the scope of the accreditation. So we have some accreditations which we are considering them hospital-wide. The accreditation itself, it is looking to the whole organization as one body, with all its processes, with all its systems, functions, like CBAHI, like GAHAR, like GCI, like Canada accreditation. On the other side, we have some accreditations which are more specific. Here, the accreditation scope is focused or specific to a certain area inside the organization. Like, for example, the CAB. The CAB is only for the laboratory. Like, for example, now GCI, they have specific, what they are calling clinical care program certification. So you are certified only for your intensive care unit, or your ER, or dialysis units, certain area inside the organization. Also, we have Planet 3, which is focusing on the patient-centered care. So all of these accreditations are specific, is not general. Now we are coming to CBAHI accreditation. As we are going to start with CBAHI. CBAHI, it stands for Central Board for Accreditation of Healthcare Institutions in Saudi Arabia. It is the official agency authorized to do accreditation certificates to healthcare organizations, governmental and private, inside Saudi Arabia. And it is located in Riyadh. CBAHI accreditation programs, they have wide spectrum of programs, a lot of varieties. They have current programs. They have the hospital accreditation program, which is the most famous one. It is for the acute care hospitals, for hospitals. And what we are applying now, it is the third version. And we are waiting, I think next year, they are going to issue the fourth version, the new version. They have also another accreditation program for primary healthcare centers. They have also another accreditation program for central blood banks and reference laboratories. And the recent one, which is starting, I think, this year, ambulatory healthcare center for polyclinics, for ambulatory care centers. In the future, we are expecting in the pipeline to have the dental center, something specific for dental centers, and for home healthcare services or centers. So these are the future programs which will be issued by CBAHI. Their aim at the end is to have accreditation standards for each and all kinds of healthcare settings, regardless of your setting, hospital, primary healthcare, polyclinic, laboratory, home healthcare, dental. You will have your own standards and you need to follow. Today, we are focusing on the hospital accreditation program, which is focusing on acute care hospitals, providing care 24 hours per day and 7 days per week. Just to summarize, for the journey of CBAHI, it started in 2001. It was founded in Mecca as a voluntary initiative by Mecca region, healthcare region. The quality team there, they put some standards and they started to comply voluntarily to this in Mecca region, and it was called Mecca Region Quality Program. This was in 2001. In 2006, it was the first time to have the first set of national standards for hospital issued centrally for the whole kingdom. Then in 2012, we have the second edition of hospital standards. Then we have 2013, the main difference, which was created when it becomes mandatory when there is a law and a decision by the kingdom that CBAHI will be mandatory for all hospitals, governmental, private, public, whatever. Up till now, according to the last statistics from CBAHI website itself, they surveyed more than 406 hospitals surveyed, more than 1,000 primary healthcare centers, more than 100 clinical laboratories and blood banks, and 32 ambulatory care centers. And this is because the ambulatory care standards only empowered or became effective this year, 22. Now we are moving to the CBAHI accreditation program, hospital program, and we are again clarifying that we are speaking about the current version, which is the third version. And again, we are expecting the new one to come next year, fourth version. In this current version, what we have, how it is structured, we have overall 23 main chapters, and some chapters, they are including like sub-chapters. So if you are counting the total, it is 31. So the structure is like this. There is a chapter, for example, provision of care. In each chapter, we have standards, 1, 2, 3, 4, according to the number of standards. And in each standard, we have measurable elements. It may be 1, 2, 3, 4, according to the standard itself. So we have the chapter. Then inside the chapter, we have the standards. And in each standard, we have the measurable elements. This is the structure of the CBAHI accreditation for hospitals. For the eligibility of the accreditation, as we said, this accreditation is focusing on hospitals. So any hospital licensed to practice in Saudi Arabia will be enforced to go to take the CBAHI accreditation. And hospital here, we means hospital which are working, providing the care 24 hours per day, 7 days per week. They have all the requirements of the acute care hospital, and they have the license to work as an acute care hospital. This is the main eligibility criteria for CBAHI. Then we are now trying to have an overview for the chapters inside CBAHI. So we have leadership chapter. We will after this slide, we are going to take an overview for each chapter. But now we are taking an overview for the whole structure. So we have leadership chapter, we have human resource chapter, we have medical staff, provision of care, nursing care, quality management, and patient safety. Then we have patient family education and rights. This is one chapter. Under it, we have two sub-chapters. One is related to patient and family education, and the other one is related to patient and family rights. We have anesthesia care, we have the operating room, we have then a big chapter, critical care, because under this one, we have the adult intensive care unit, the ICU, we have the pediatric intensive care unit, the PICU, we have the neonatal intensive care unit, the NICU, and the coronary care unit, the CCU. So this, the chapter, the big one, critical care, and under this one, we have 4 sub-chapters. And this is why we said that overall, it is 23 if we are counting the big chapters, but if we are counting the sub-chapters also, we will have 31. We have also labor and delivery, hemodialysis, emergency care, radiology services, burn care, oncology, and radiotherapy. And then we have another big chapter, including sub-chapters, specialized care services. Under this one, we have all the other specialties like dietary services, like social care services, pediatric and respiratory care services. Then we have dental care and management of information and the medical records, which is divided into 2 sub-chapters, one related to the management of information, and the other one, it is related to the medical records. Then we have the infection prevention and control, the medication management, the laboratory, and the facility management and safety. So this is the overall structure of CBAHI. Here we can, if we have some of our colleagues who has any experience or she has any experience with GCI, we can find, which is the most famous worldwide, we can see one evident difference in the structure of the chapters. Can any one of our colleagues tell us if he has any experience about GCI and difference between here and CBAHI in the structure of the chapters itself? Okay, so we have Mr. Rifat. So what is the difference? From you have now this one, and you have an experience with GCI. So from your point of view, what is the difference? Where is the difference? Okay. For those who have any experience with GCI, they will never find what we are calling departmental chapters. In GCI, there are only functional chapters. And you will find a chapter called provision of care, assessment of patient, care of patients. So each chapter, the focus here is a complete system or a complete process. It is not specific for a single department. You will not find a chapter called ER or hemodialysis or OR, something like this. This is in GCI. In CBAHI, we have the two kinds of chapters. We have functional chapters like provision of care, like quality management, like, for example, management of information, like infection prevention and control. Here we have a complete system. The chapter is focusing on this system. And we have on the other side also some chapters which are departmental chapters, including standards specific to a certain unit or a certain area inside the hospital, like the critical care and all the sub-chapters, ICU, BICU, NICU, CCU. So this is one of the main differences between GCI and CBAHI. Let us start by the readership chapter. The readership chapter, this chapter is addressing the rules and responsibilities of the readership group for several processes. Here, this chapter, it is the one speaking about how the hospital is going to write. Okay.
Yeah, so I think here we have Mr. Rifat Shaheen, I think, not Rifat Shaheen, sorry. Rifat Shaheen, Dr. Rifat Shaheen, talking about that CBAHI is very detailed, as you rightly said, and has more measurable standards. And,
yes.
And CBAHI has also has ESR before the details.
Yes, yes, Mr. Rifat, thank you. This is also one of the features characterizing CBAHI from GCI. They have the process of ESR, essential safety requirements. So this is one of the features. Even those who are reading the phrasing of standards in GCI and CBAHI, they will find difference not only with GCI, but even with Canadian accreditation, with Australian accreditation. This difference is mainly coming from what? It is mainly coming from writing a global accreditation. So you need to write the standard somehow flexible, because the GCI will go to visit a hospital in Japan, in Saudi Arabia, in Egypt, in Spain, in Brazil, and they cannot put a detailed, very tight standard because the difference, the circumstances, the atmosphere, the everything is different. But CBAHI, because it is written for Saudi Arabia, so it is very specific, it is very detailed. Some standards are very, very tight because it is written to the local circumstances. For example, if we are mentioning the head of department, for example, then as one of the examples, we can, if we are going to read the GCI or CBAHI or GCI or Canadian or whatever, they will speak about that the head of department should be a qualified physician. That's all. Because qualified will be translated in different meanings in each country. But if we are going to CBAHI, which is written for Saudi Arabia, they will write the head of department should be licensed as a consultant in the Saudi Commission of Health Specialists. So it is very, very specific. For example, if we are going to the crash cards which we are using in cardiac arrest and in all these emergency situations, if we are going to the global accreditation like GCI, it will speak about that crash cards are available and equipped with the required medications and required equipment. Because, of course, medications are not the same in all countries all over the world. But in CBAHI, you will find that the crash card should include 1, 2, 3, 4, 5 mentioned by name. So here, the difference in details. Those who are working with CBAHI, they will find this very, very evident in the lab section, for example. The lab section in CBAHI is very long, very detailed, targeting every single step inside the lab with full details. So the ESR is one of the main features. Having departmental chapters besides the functional chapters is also another features characterizing CBAHI, and also the details and the specific details written in many standards. These are the main three features characterizing CBAHI.
Yeah, and Saida Naz is asking, in JCI, is JCI only departmental? So we'd like to answer that question. She's asking.
No, the GCI, all the chapters in GCI, it is functional. Care of patients. Who is responsible? All the hospital. Assessment of patients. Medication safety. So you will never find a chapter called pharmacy, or you will never find a chapter called ICU, or it is speaking about the whole function or the whole process. In CBAHI, we have both kinds. We have some chapters like this, but we have also chapters which are defined for a certain unit or a certain department.
Okay, thanks, doctor, for answering that question. Now, yes, so let's move on to the leadership chapter. Yeah.
Okay, so for the leadership chapter, it is the chapter speaking about many areas related to the leadership of the organization. Here, it is speaking about the mission, the vision, the values, how the hospital is going to do this, even the organizational structure and what is the requirement, and how the relationship is organized between the governing body, which may be the owner or the Ministry of Health or the Ministry of National Security Guard or whatever, and the hospital leadership actually responsible for the daily operations. How this connection is well established and well organized. Also, how the hospital is going to construct or to formulate strategic plans and operational plans, and how they are considering the community needs during this stage, financial management. Even there is some standards related to what we are calling the outsourced contract. In many hospitals, we can find certain functions outsourced, given to a third party to provide inside the hospital, like security, like the kitchen. Like some hospital, even sometimes we have these contracts in some of our clinical services. For example, a hospital, they have a radiology department, but the readings, the interpretation of the radiological studies through telegraph, through the e-medicine and through the telemedicine, it is done by another hospital. So all of these services, they are outsourced to another third party. Here, the standard is very specific that, of course, although you have outsourced these services to the third party, but you should be responsible to make sure that they are providing this with all the standards required according to CBAHI. And you should monitor their performance. You should justify why you selected this provider and how you are monitoring them and what actions you are taking if they are deviated from the required performance. The responsibilities of the governing body, the responsibilities of the hospital leader and the department heads. All of these areas are included in the leadership chapter. So as we said, we are speaking about having executive management committee structure, that we have a committee, executive committee, and what are the structure of this committee, who should be included. And they are mentioning also all the other required committees to be present inside the healthcare organization. They are speaking about continuous quality improvement training for the hospital leadership in quality tools, in root cause, data analysis, the basic at least to be with them. How you are doing your assessment for the community needs and how you are involving the community in your planning process, and the planning process to be done through a collaborative approach, and it should cover areas like budgeting, like staff needs, and quality improvement plans and project all should be done multifunctional and multi-departmental, not only by a single unit or a single part. The contract oversight is one of the important parts, and supply chain, especially for the essential supplies and essential medications, and how we are going to optimize the patient flow. All these areas are mentioned through resource and the workforce. Here, how we are attracting the manpower, how you are orienting new staff, how you are verifying the credentials of your healthcare professionals, how you are putting training and education plans to ensure the professional growth of your staff, how you are making sure about their competency, their privilege, job descriptions, what should be included in the personal file, the staff health and staff compliance and staff satisfaction. All these areas. So here, the human resource is speaking that we need to see good collaboration between the department heads. For example, the internal medicine department head and the human resource department in putting the staffing plan, in selecting the new staff, in putting training needs, and they need always to see the involvement of the departmental heads in this process. It is not only the human resource department doing everything from A to Z, while the head of departments are totally detached from this area. Also, the personal files and what to be kept inside this personal file is very important, and it is well explained in this chapter, because in the process, survey process, after this, when we are going to explain, we have a complete session related to the personal file, auditing the personal files of your staff. Another very important and critical area, and it is one of the ESR, is the primary source of verification for everything related to your healthcare professionals. You should, whatever licenses or certificates or qualifications coming with your new staff, you have to verify them from the original source, from the issuing university or the issuing institution or whatever. So you are making sure that these people are bringing you original documents and you can trust them in providing care for your patients. This is one of the ESR, 20 standards, ESR standards. We have 20 standards, and this is one of them. Also, the training needs. Then also in this chapter, all the cardiopulmonary resuscitation certificates for different categories of positions are explained, who should be certified in what. Also, the staff health and safety is one, and the orientation program, and how you are monitoring the staff satisfaction through surveys, through exit interview. All of this is addressed in this chapter. Then we have the medical staff. The medical staff chapter, it is speaking about the medical staff as a total: leaders, rules, responsibilities, evaluation, credentialing, privileging, the medical staff by law, which is very important, and even the medical staff committees. Some committees are medical in their nature, like the medication safety committee, like the medical executive committee. So they are speaking about this area, and the collaboration between medical staff and other disciplines inside the organization, and the competency assessment of your medical staff. Here, one of the most important documents, we are speaking about the medical staff by law, how it is developed and how it is approved and communicated. They are speaking in this chapter about the medical director qualifications and responsibilities, the medical executive committee, including the medical director with the head of departments of clinical departments, of course, and the head of clinical departments, their qualifications, their responsibilities. The credential and the privileging process in details is explained in this chapter. And another area, which is the ongoing professional practice evaluation. Here, they are requiring for those who are healthcare practitioners, physicians mainly, beside the routine evaluation, speaking about absenteeism, about attitude, about coming on time, all these routine assessment, they need to have technical evaluation related to their practice, ongoing professional practice evaluation. And based on this evaluation, which should cover areas like professional growth, like clinical practice, like even attitude and behavior, all these three areas, mainly, this should be reflected in their privilege. So from this evaluation, for example, if a physician is not performing well in a certain, for example, surgery or procedure, so you need to reflect this in the privilege. If this privilege is given to him, you should revise, you should hold, you should put under supervision, take any action matching with the result of the ongoing practice, professional practice evaluation. Then they are mentioning all the committees which are we considering medical committees, because most of the members are from medical areas: physicians, nursing, clinical departments, medical record, like utilization committee, morbidity mortality committee, tissue review committee, medical record review committee, blood utilization committee, operating room committee, and CPR committee. All these committees are required to be there in standards, and to have for each one of them the terms of reference explaining the structure, the rules, responsibilities, and the members of these committees. Then we have the provision of care. The provision of care, it is speaking about how patients are going to be screened in the organization, the access to care, registration and admission process, scope and content of patient and assessment and reassessment, how the plan of care is going to be developed for each patient, the continuity and the coordination of care. So we are avoiding the fragmentation of care, which is one of the main reasons for having incidents, medication errors, medical errors, all these coming from the fragmented care. Consultations, high risk and vulnerable patients, how they are going to be managed inside the organization, psychiatric patients, and all the areas related to patient discharge, transfer, and referral within the hospital or outside the hospital. So the standards are speaking about providing uniform standard of care to all patients. We have a standardized process for patient assessment, initial assessment to be completely documented in the medical record. And we have here the initial medical done by physicians, the initial nursing done by nurses, and the specialized assessments, which is going to be done by other specialties like the dietitian, like the physiotherapist in certain cases when indicated. Even the discharge planning and discharge process, which should be started very early. Also, the standards are speaking about very clear concept of having one qualified physician responsible for the overall coordination for each case. We are calling this one MRP, most responsible physician. So for each case admitted to the hospital, we should have a clearly identified MRP. The pain management process, the plan of care, how we are going to develop plan of care, how it is well communicated among all the healthcare involved healthcare practitioners, clinical practice guidelines, protocols, pathways, all this area also is present in this chapter, and the pre-operative checklist for both patients who are going to the OR also it is in this area. Then we have the vulnerable patients. Vulnerable patients, those group of populations who are at higher risk inside the organization, like temporarily ill, like psychiatric, like patients who are comatose, immunocompromised. So those populations, they need special treatment. They need specific policies addressing the specific risks liable to happen to those categories of patients. Also, the use, handling, administration of blood and blood products, which is a very sensitive and important area, and it is one also of the ESR requirements, is also mentioned in this chapter. CBR, also rapid response team, which is very important concept, how we are going to identify and to deal with deteriorating patients who are starting to deteriorate, so we can interfere before reaching to a very critical level. And then the transfer process, how we are going to transport our patients to another organization, or even how to transfer the patients to another facility. All of these process standards are mentioned in this chapter. And the continuity of care, speaking about the discharge process, the referral, the follow-up, the discharge instructions also in this chapter. Then here we have nursing care, which is here related to the nursing department mainly. So it is speaking about the nursing department organization, staffing, the role of nursing director, how nursing department is going to collaborate with other departments, the nursing standards of practice, nursing assessments, nursing plan of care, so nursing education. So it is focusing on nursing department with all the aspects related to this one. So here, how nursing director is going to be selected, what are the main rules and responsibilities for nursing director, policies and procedures for effective nursing services, the nursing reference manual and policies, including the policies in different nursing units, how nursing staff competency is going to be assessed, nursing staffing plans, and how we are doing very common in hospitals, the pooling process, which areas can cover another areas, allocation of nurses in working areas according to their qualifications, assignment of nurses out of their normal working areas, which require cross-training plans, comprehensive nursing assessment for each patient upon admission, with covering all the required areas according to standards like the physiological, like the functional, like the nutritional. All these areas should be covered in the nursing assessment. And the nursing care plan, how it is developed for every patient, and how they are going to collaborate with other departments to ensure the provision of adequate supplies and equipment and safe environment to provide care. Then we are coming to the quality management and patient safety. And in this chapter, we have also a lot of areas, a plan and organization-wide approach for quality improvement, the required structure for quality management, and patient safety. And here we are speaking about the quality management and patient safety committee, and the quality management department and the quality management program, all the requirements for each one of these areas, data collection and data analysis and data interpretation, and all the data management process is clearly explained here. The risk management process, how we are going to set priorities for improvements based on data available, the patient safety program, also how we are dealing with different kinds of significant events, sentinel events, how we are identify those events, and what we are doing as a response to those events to ensure that root cause analysis is done in all cases like this, and the incident reporting and management system. So here we should have a program, and the program is usually for several years, usually 3 years. And from this program, we have an annual plan. So we have quality improvement program, for example, 22 to 24. And then each year we have an annual plan for quality improvement. The same can be applied for risk management. The same can be applied for patient safety. We have a program, and then we have a plan. Then also how we are selecting the director of quality department, what are the requirements, and even the staff working in quality, the standard related to the data management also mentioned here, and the OVR system and how it is managed, and how OVRs are analyzed to extract information which can be reflected in performance improvement, and the safety of the alarm systems for patient care equipment. All of these areas are mentioned, covered in this chapter. Besides this, also some of the international patient safety goals, which we are famous coming from JCI as one chapter. Some of them are mentioned here, like the patient identification process, like the communication process, like but we are the wrong site, wrong patient, wrong surgery. So these standards are related to patient safety, and they are mentioning clearly what should be done as precautions to ensure correct identification of patients, to ensure handover communication, reporting of critical values. All this is mentioned here. Verbal order, telephone order. So all these areas or these parts are coming under patient safety. And if we are going to compare them, they are related directly to the international patient safety goals. In this chapter, one of the very important areas discussed here or explained here is the committee. So there is a possibility for any hospital to have patient safety committee and quality management committee, and it is allowed for the hospital even to have one merged committee, which is usually done by most of organizations responsible for quality improvement and patient safety. This one should be including representative from all the areas, all the departments. It should be chaired even by the hospital director or the highest authority inside the hospital. This is very important, and it is explained in details. Also, the assessment of patient safety culture on annual basis should be done according to the standards of quality management and patient safety. And this, as we know, the 6 patient safety goals, international patient safety goal, related to patient identification, related to effective communication, safe medication, related to the safe surgery, avoiding wrong patient, wrong site, wrong procedure. And then the goal number 5, which is related to the infection, reducing the healthcare associated infections. And the goal number 6, which is related to reducing the risk of patient harm from falls. So these are the main international patient safety goals addressed. In JCI, we have one complete chapter about them, but in CBAHI, we have most of them in quality management chapter, but we have some of them even mentioned in other chapters. It is not all of them in the same chapter on a specific chapter like JCI. Then we have the patient and family education. It is one of the smallest chapters and with very few standards about the educational resources, about the role of health educators, how to develop an educational plan for each patient and to customize this plan based on his needs, on his status, and the effectiveness of such education. And according to standards, they are requiring, according to the hospital size, to have health educator and diabetic educator. And according to the size of hospital, it can be increased, the number can be changed. Then we have also the patient educational needs And the involvement, one of the most important issue is to involve patients and families in the education process, in the orientation process, as long as we can, like in situation like taking consents, participating in care process, understanding the care choices available to them. And all these educational activities provided to the patient by the nurse, by the physician, by the dietitian should be reflected and well documented in the medical record. Then we have the patient and family rights, the other sub-chapter under this area. And in this chapter, here we are speaking about all kinds of patient and family rights. We have also how to protect vulnerable patients, pain management process, how we are going to protect patient belongings, also the informed consent process when it is needed and when it is required, and how we are going to take the informed consent, because here we are speaking about the informed consent, not a consent only, but an informed consent, and how to make sure that patients and families are fully informed and protected if a hospital is conducting any kind of research for those hospitals providing this service or having this service. So here we have very clear mentioning for having a specific committee for patient rights, and patient privacy is one of the most important areas explained in this chapter. Also, protection of patients from negligence and abuse, especially for vulnerable populations, policy for protecting the personal belongings, especially and the responsibility of the hospital in this area. Also, the confidentiality of the patient information and the informed consent before high-risk treatment and procedure, and should be clearly defined in the policy. And informed consent here, we mean that the patient is well informed about everything before the treatment or before the procedure. Then the patient is going to sign the informed consent. It is not only just to sign the consent, even, for example, it is not sufficient, for example, to write the name of the procedure and then the patient will sign. This is not an informed consent. The informed consent should include the name of treatment, the name of procedure, the complications expected, the any kind of risk associated with this one, all the alternative treatment, if any, and then the patient can sign it as an informed consent, which means that we explained everything to the patient, and then the patient is going to accept and sign. It should be explained to the patient in the language he can understand, and even we are going to utilize plain language in informed consent. Abbreviations, medical terminology, any kind of complicated abbreviations not understood by the patient, it is not accepted. Very famous finding and very famous observation, even we are noticing in many organizations. For example, CS, which is standing for cesarean section. Even if this is accepted in the medical documentation when physicians are referring cases to each other, but once we are going to write the informed consent, it cannot be accepted to write CS. The patient need to read cesarean section written clearly, and then he is going to, after reading the complete consent, to sign. So informed consent, as we said, it should be always done in the way and in the language which can be understood by the patient. Also, how we are going to deal with no code policy or no CPR policy for cases which will not be resuscitated. Also, this should be organized through a policy. How we are dealing with patient complaints, and how we are dealing with ethical standards, ethical dilemmas, and also for organizations who are which are doing organ donations or organ transplantation. Also, there is some standards related to this area. And here also, in this standard, we are speaking about how we are going to get the feedback from patients, not only through receiving complaints, but how we are doing this in an active way, through surveys, through interviews, in different kinds to get their feedback. Then we have the anesthesia care. The anesthesia care, it is speaking about the anesthesia department, staff, qualifications, equipment and supplies, assessment pre-anesthesia and during the anesthesia, and even in the recovery, and the conscious sedation, which is very important because it is one of the ESR also. So here we are starting by qualified head of department, the anesthesia staff members having appropriate qualifications, and it is determined that, for example, anesthesia consultant should be responsible for doing anesthesia for certain procedures like pediatric procedures, like cardiopulmonary operations, neurosurgery, transplant. So consultants are only responsible for this, and it is determining policies and procedures which should be guiding the provision of care in anesthesia department, and what kinds of forms or records are required to be documented in the medical record of the patient related to anesthesia. And then another important area is the moderate and deep sedation, where we are allowing to do such procedures in the hospital, who are allowed to do this, and how we are going to monitor this all the time, and qualified staff perform moderate and deep sedation based on certain criteria, and they have official privilege, and what are also the policies guiding all these processes. Then we are going to the OR. In the OR, we have the staffing and qualifications of the operating room, requirements before surgery, documentation of the surgical procedures. There is also some standard related to the daycare surgery, the infection control inside the OR, and the post-operative care. Here we have the qualified individuals also directing the operational room. Here we have a complete list with all policies and procedures guiding the care inside the operational room. The qualified nurse manager also supervising the area. There is a policy for the daycare surgeries, the pain management for surgical patients, and the measures against fire, the measure against infection, spreading infection inside the OR, the post-operative care plan with all the elements required according to standard. It is clearly mentioned here in this chapter, and the operative report and what should be included inside this operative report, and any tissue removed from the patient during surgery must be sent to be examined in the pathology department. Then we have the critical care services, and this one, it is a chapter addressing the staff qualification and plan, the equipment and supplies, the admission and discharge criteria, the proper intensive care practices and discharge procedure. And under this one, it is covering the 4 critical care areas in any hospital: the adult one, the pediatric one, the neonatal one, and the coronary or the cardiac one. So we have 4 kinds of critical care units covered under this big chapter. In the adult ICU, in all of them, the structure is almost different, similar. So we are speaking in each unit, we have a qualified physician, and we have a qualified registered nurse as the head of department for physicians, and as the head nurse or the nurse manager for the unit, and also the required qualifications for cardiac life support training for those who are working in this unit, the admission and discharge criteria for the unit, and the effective handover process when giving, receiving, or transferring patients outside the unit, and even the multidisciplinary approach inside the unit, the care plan from physicians and nurses, and the adequate equipment and supplies in this unit, the infection control standards, and even there are some standards speaking about organ donation if done inside any hospital. And the same will be seen in the pediatric ICU, also having qualified physician, having qualified registered nurse, even the relevant cardiac life support training pulse, for example, for them, the admission and discharge criteria, the handover, and the infection control. It is almost the same like the adult ICU. Then we have the neonatal intensive care unit with the same requirements: a qualified physician to supervise the unit, to be the head of the unit, qualified registered nurse, the relevant specific cardiac life support, the NRB in this case, the admission and discharge criteria, the handover process, the multifunctional approach in caring for patients, the infection control guidelines, and the equipment and supplies and diagnostic services which should be available to support the work inside the unit. The same can be seen also for the coronary care unit, the same requirements. So all these 4 critical care units are covered in this big chapter with 4 divisions. Then we have the labor and delivery. Here we are speaking about the staff qualification and plan, policies and procedures, high-risk patient, equipment and supplies, the midwifery and nursing services, the admission and discharge criteria, the medical records for obstetric department. And here, qualified physician to be the head of the obstetric department, qualified nurse also. They have their own specific cardiac life support also. at least to be one certified every shift. They have also admission and discharge criteria in the unit. There are also adequate coverage by qualified medical and nursing staff members, the policies and procedures to guide the work inside the unit. How we are, this is very sensitive. Labor and delivery unit is the area where after delivery, the babies will move now to the nursery unit or to the NICU unit. So how we are handling this process? Baby identification in the first moment, baby and mother identification to prevent one of the worst case scenarios in any hospital, which is discharging wrong baby to wrong family. So there is a complete process guiding these very, very critical moments, and good orientation and training for nurses who are working in this area for applying this policy, and all the documentation requirements in the medical record for obstetric cases. Then we have the hemodialysis. Again, here we are covering staff qualifications, policies and procedures to be followed in the dialysis unit, plan of care for patients, water management, infection control, nursing competencies, and equipment and machines. So here, as we used to say in the other chapters, we need qualified physician to be the head of the unit, qualified nurse to be the clinical nurse manager or the head nurse in the unit. The complete documentation of the care provided to those patients, admission and discharge criteria, policies and procedures guiding the care of patients in this unit. Equipment and the machines should be in good working conditions with preventive maintenance. The water quality to be checked according to the standards, bacteriology testing on monthly basis, for example, chemistry testing on annual basis, and should be all the staff working should be trained on the equipment or machines, dialysis machines inside the unit. And competency, specific competencies should be available for those who are working in this unit. Infection control guidelines in the unit is very important. How we are segregating, for example, those who are non-infectious cases with separate area, with separate machines from those who are considering for us infectious in another area. So, for example, in Egypt, for example, we have in the same unit 2 or 3 machines for hepatitis C positive, while totally separated from the other machines for hepatitis C negative. The same in any area. So you are making sure that you are reducing the risk of infection to the minimum inside your hospital. Then we have the emergency care. The emergency care here, again, the staff qualification, plan, availability, equipment, and supplies. Here we have a specific process in ER only, which is the triage process, how they are triaging cases after their arrival to the ER. So we know that this is triage category 1, which should be seen immediately by the physician. And those patients are coming with triage category 4 and 5, who can wait for 60 minutes or 40 minutes or 50 minutes, because in ER, patients are arranged according to the triage category, not like clinic, for example, according to the time of arrival to the clinic. The policies and the procedures, the patient assessment and care, and the medical record and documentation. And here we have all the standards, qualified physician, qualified nurse. Here also they have adequate coverage from physicians and nurses in the area. What are the policies and procedures to be available in the ER to guide the workflow inside the OR area, the ER area, like how to care for trauma patients, how to deal with minors like children, how we are going to transfer patients from ER to inpatient areas, or even transfer them to another organization, even if the patients are willing to leave against medical advice. What is the process? All these, how to are going to management of suspected victims of abuse or neglect, because these cases are frequently seen in the ER department. So all these areas should be covered through policies inside the hospital. And here again, the most important issue is the triaging process. This is one of the main processes inside the ER area, because it is organizing all the patient flow after this. Also, how we are organizing the consultations in the ER, because they are always requiring consultations from other departments inside the hospital, how they are following the infection control guidelines, and what kinds of indicators should be present in the ER department. And according to CBAHI, they are requiring, you can select any indicators, but they are requiring certain indicators to be monitored and to be followed. The time for those patients with chest pain, time to ECG, time taken to do the ECG, and time to antibiotic in sepsis cases, and triage to physician time, the time taken from arrival to see the physician according to the triage category. And also the ambulance services are covered under this chapter. The radiology chapter, here again, we are speaking about the staff qualifications, plan, availability, equipment and supplies, how we are reporting critical. Here in the lab and radiology, again, we have a very specific area which is reporting panic values or critical values. How this department is going to make sure that critical values are reported immediately to the requesting physician in a clear way so he can take the decision, and then the safety and intervention radiology for those departments providing interventional studies. So it should be managed by qualified physician, and the radiology department has enough staff, policies, and procedures to be available, mentioned in the standard of this chapter. And here also we have the very important area which is reporting critical values, and that the availability to access the radiological studies at any time, because you are speaking about a hospital, 24-hour, you are ready to provide care for the patient, and the safety of diagnostic imaging equipment and diagnostic imaging department. This is one of the characteristic features in radiology department. What is the safety program in this department? How we are making sure that the department is safe for staff, for patients, and for the whole organization. We have a lot of requirements in the standard of CBAHI addressing this one, and one of them, one big standard from them, is one of the ESR also. We have the burn care for those hospitals having a burn care unit. Speaking about the staff, admission and discharge criteria, policies and procedure, infection control guidelines, and collaboration with other departments. And the start is usually having qualified head for the unit, usually from plastic surgery, qualified head nurse, and admission and discharge criteria in all specific units. We should have clear admission and the criteria, discharge criteria, which are physiologically based. They are related to the parameters of the patient, the condition of the patient, not on any other issue, and the policies and the procedure to be available in the unit, and infection control guideline for the unit. Here we have also another chapter which is related to the oncology and radiotherapy for those hospitals providing this service. Staff qualification, safety plan, admission and discharge criteria, and policies and procedures. So again, as we used to say, we have a qualified physician as a head of the unit. We have full compliance with all relevant regulations. We have also policies to guide the provision of care for patients in this unit. We have nurse manager to supervise the unit, and the documentation for everything in the unit. And here, for those hospitals having oncology and radiotherapy services and dealing with patients with malignant tumors, they should have a committee guiding the workflow and guiding the provision of care for such patients. Then we have specialized care services, which is covering 4 areas: the respiratory care services. Yes.
So as we are those who have joined in between, we just wanted to welcome them, and also we are discussing the different chapters right now of CBAHI, and we are talking about, we are giving in the overview, and we have Saida Naz asking for one question that they tell that policies and procedures should be there. Who and how will we prepare? So I think maybe after the chapters are discussed, we'll talk about it. We just wanted to Saida.
Yes, after finishing the chapters, we are going to give an overview for the process itself, how they are surveying the hospital, and what we need to provide as hospital to them.
Yes, and the one more question she's asked is that for polyclinic, what CBAHI recommends. So that also, I think, after we discuss the chapters, we'll be talking.
Okay. So here, specialized care services, we have 4 kinds of services which are provided by specialists, not physicians, like dietitians, like social workers, physiotherapists, and respiratory specialists. So in the 4 areas, there is mentioning what policies and procedures should be present to guide the provision of this service. in respiratory service unit, they should be supervised by a qualified physician, and according to standards, you should select as a hospital between the pulmonologist, the anesthesia, and the intensive care unit. One qualified physician from one of these areas should supervise the work and the clinical activities of the respiratory care services department or unit. And we have a qualified head for this unit, which is having a lot of rules with certain criteria according to the standards. And this service should be available 24 hours a day, 7 days a week. Also, the equipment and the machines available is important to be also addressed through the policies and procedures of the department. And the competency of those staff should be also clearly explained in the policy and to match with all the requirements of the CBAHI standards. Then we are coming to the dietitian. So also to be the unit to be supervised, to have a qualified dietitian, and also the nutritional assessment to be performed by qualified dietitian, and the nutritional screening, which is done usually by the nurses, should be modified or should be developed and reviewed by these dietitians. Even if the nurses are going to do the nutritional screening, but the criteria included, the form, the way of the screening should be revised and should be approved by the dietitian because they are more qualified in this area. Then all the dietary manual, to have a dietary manual, which is should be updated, available to the hospital, how to deal with therapeutic diets whenever indicated for certain kind of patients, and how we are integrating the nutritional care plan with the patient care plan. And we are making sure that the communication between the physician, the nurse, and the dietitian is always well integrated and effective to ensure that all the goals identified in the care plans are achieved. When we are coming to the social worker area, also it should be headed by a qualified social worker, and there is psychological risk screening done by qualified staff, which are usually the nurses. This screening criteria and form and way of screening should be revised and approved by the social worker. Then we are coming to the comprehensive assessment for indicated cases by the qualified worker, by social worker, and policies and procedure guiding when and in which conditions the psychological assessment or the social work involvement will be necessary, will be mandatory. But according to standards, we have different criteria for this. And also the provision of effective social care services for inpatients and outpatients according to the identified criteria in the policies and procedures of the hospital, and how all of this will be documented in the medical record of the patient. For the physiotherapy services, it should be provided by the qualified therapist, and we should have a head for this unit who is a qualified physiotherapist, and all staff members should be qualified and licensed according to the laws and regulations. And we have policies and procedures and protocols to guide the provision of care to patients coming to this unit. Patient identifies at function risk, also having the complete assessment done by the physiotherapy specialist, and how we are also documenting all of this in the medical record of the patient. Then we are moving to another chapter, which is the dental care. The dental care, here we are addressing the staff qualifications, the patient and family education, the patient assessment and care, documentation in the medical record, patient education, infection prevention and control, and safety in the dental laboratory for hospitals having a dental laboratory. So a qualified dentist should be the head of the dental department or the dental unit, and dental department should have appropriate qualification. We are speaking here about the dentist, and also we are speaking about the dental technicians, and we have one dental assistant per dental chair. This is one of the ratios identified by CBAHI. Education to the patient and family, how we are going to do this for dental patients, and what are the proper complete documentation in the medical record for everything. Also for dental department, it's very important to have policies and procedures guiding the informed consent, obtaining informed consent, and the deep and moderate sedation, and of course infection control guidelines also should be clearly explained and implemented in the dental department, and the safety rules if we have a dental laboratory. For the management of information, which is another chapter, we have here two main areas. We have the medical records and the management information, which is related to the healthcare technology. So if you are starting by the management of information needs assessment, information planning, data collection analysis, information flow and reporting requirements, and security, integrity, and confidentiality of information. Of course, this is more even evident in hospitals which are using electronic medical records, because all of the data, most of the data is present in the healthcare information system, and the confidentiality, security, integration of data should be also clearly explained in the related policies. So here we are speaking about the process of information management, modification, updates, how data are going to be collected, transformed to information, and then provided to those who are going to take decisions. Also, there is a policy and procedure for confidentiality, security, integrity of data. Also, the conduction of needs assessment from those who are managing the management of information department or information technology department, with all clinical and managerial leaders to identify what are their needs and how we can provide these needs to them. And also, if there are some needs or requirements from external organizations like regulatory authorities, like accreditation bodies, like insurance companies, also how this can be managed in the organization. Also, the area of having clear documentation, no abbreviations, no symbols, or standardized definitions for approvals, approved abbreviation and symbols should be also mentioned. Retention of data and information should be also mentioned and explained in the policies. And from also the other area, data backup, how we are going to do the data backup if needed. And also the process of obtaining information from administrative and from clinical departments, how they are going to request for information, and how the process will flow inside the organization. For example, for the backup, if, for example, even if you are working with an electronic medical record, for example, healthcare information system, we need to test if the system will shut down due to any reason. What will be done? What is the backup plan? What is plan B to ensure the continuity of the services even in these conditions? This is one of the very sensitive standards in this chapter. Then we have the medical records, and here we are speaking about the medical records department staffing, the initiation, construction, and contents of medical records, the coding, the availability of the medical record, storage and retention of medical records, the security and safety and confidentiality of medical records, and how we are going to improve the quality of our medical records. And here we have the medical record department, and it is explained what are requirements, what are the main requirements to qualify the staff, departmental director who is qualified, clinical coders. All this should be mentioned clearly. Also, there is the medical record committee, which should supervise the whole process related to medical documentation and the medical records. And for each patient, this is very clear. For every patient, we have a single unique identification number and specific medical record with this number. And also to have a master patient index, either manual or computerized, for patients who have been admitted or treated by the hospital, so the data can be retrieved at any time. Even delinquent medical records, how we are going to complete them, and how we are accepting the proper inputs inside the file to be legible, to be timed, to be dated, to be stamped. Everything should be clearly explained in the policy. And the storage of the medical record should be in one central place. This place should be protected, secured from any unauthorized access, even safe from fire risk by certain parameters and by certain requirements. How we are going to track medical records, what are the rules and responsibilities of the medical record committee, and how we are monitoring the completion of medical records inside the hospital. All these policies of the medical record department should clarify and identify how all these processes will be covered and will be done. Then we are coming to the infection prevention and control. In infection prevention and control, we are speaking about the program, the education, the PPE, the hand hygiene, the sharp safety. We are speaking about the sterilization and disinfection, healthcare associated infections, employee health, blood exposure, communicable diseases, waste management, laundry, infection control precaution during renovation and constructions. It is one of the big chapters inside CBAHI, and it is becoming more and more important after even the pandemic, COVID pandemic, with all the focus on infection control guidelines and precautions. So here we are speaking about qualified professional to direct the infection prevention and control program. Also, we have a very specific committee designated multifunctional, including the senior leaders and representatives from all areas, which is so responsible to supervise the whole process. Also, there is a program to reduce the risk of healthcare associated infections for everyone, patients, visitors, staff even. We have, from this program, we have annual plan, which is done and monitored every year. We have policies and procedures covering all areas related to infection control, reporting communicable diseases to regulatory bodies, how this is done. The CSD, Central Sterilization Service staff and qualification and the processes also is coming under this chapter. Also, we have also the sharp injury, the needle stick injury, and the management of this process also is coming under this chapter. The continuous monitoring of healthcare associated infections and analysis of data and taking proper actions based on this data is coming here also. And how we are going to manage and investigate the outbreaks of infectious diseases. In this chapter, as we said, we have a lot of laws and regulations we should be strictly following inside the organization related to, for example, medical staffing, related to the single-use items, related to the infection control guidelines, related to the triaging of patients and the flow of patients under certain clinical conditions. So all of this should be strictly followed. The hand hygiene area, as we said, the regulatory authority reporting to them the communicable diseases. And one of the important area also addressed in this chapter explained is the regularly reviewed antibiogram. It should be done on annual basis. Also, from this chapter, there is clear explanation in more details which can complete the area mentioned in the human resource. This area related to employee immunization, post-exposure management, staff health. So this area, it is partially covered in the human resource, in the administrative issues, and it is partially covered in the infection control, prevention and control in the technical issues. So both of them are completing each other in this area. Here there are also requirements to follow all the bundles, the IHI bundles, the VAB, the CSI, the UTI, the CLABSI, and the multi-drug resistant organism. All the bundles mentioned by IHI should be clearly and strictly implemented by the hospital. And even there is a clear standard speaking about the staff accommodation. Then we are coming to the medication management. The medication management, here we are speaking about staff qualification and planning, staff education, selection of medication, storage, ordering, all the phases of medication management system, administration, monitoring, evidence-based practice, monitoring the medication errors and the near misses. So everything is mentioned related to this area in this chapter. It's one of the biggest functional chapters in CBAHI. So here we have the pharmacy department, and we have a clear mentioning about the committee, which should be including multidisciplinary members from different departments, and should supervise everything related to medication safety. We have also the drug formulary inside the hospital, which should be well updated and well organized. We have also the connection or the relationship with the Saudi FDA and how this is well organized by the hospital, and the high alert medications with everything related to the safe use of them inside the hospital, the look-alike, sound-alike medications also. Then we are coming to the area of procurement or supply chain of medications and how we are ensuring that it is always continuous. Also, the storage of medications and handling of them. We have also the crash cards and how we are monitoring, securing the emergency medications inside the crash cards. And also there is a specific system for using and storing narcotics and other controlled medications according to laws and regulation. Also, a system for prescribing antibiotics. Telephone and verbal orders also should be mentioned in a policy. The appropriateness review for medication orders, the system for educational in outpatient areas, also the how we are handling the recalls, the damaged medications, all this should be clearly mentioned in the policies of the hospital. And then we have the area related to the managing the adverse drug events, reporting and managing adverse drug events, monitoring and identifying significant medication errors, including near misses, hazardous conditions, and at-risk behaviors. And this is one also of the ESR requirements inside CBAHI. Then we are coming to the lab. The lab, we have here the physical structure and of the medical laboratory, staffing plan and qualification, the safety program, the specimen collection, the equipment management, labeling, reporting results, quality management program, point of care testing, blood bank and blood transfusion services if present, and anatomical pathology. And this is one of the biggest chapters. It is almost more than 70 standards mentioned in details in CBAHI. So it is very big and detailed chapter. And here we are starting from the main areas that it must be carried by qualified staff, and there is a qualified head for the department, the competency assessment program for the staff working in the lab, the supply chain management for everything related to the lab, especially critical materials, the management of the equipment, validation and testing inside the lab, also the infection control guidelines to be followed inside the lab. Then we have monitoring the turnaround time inside the lab for routine test, for stat test, for everything inside the lab, the results, the turnaround time should be monitored and action should be taken based on this. The laboratory developed process for the labeling of a specimen, the handling of a specimen, how we are receiving specimens, and how we are doing specimen retention. And there is also another area which is very important, which is point of care testing. Point of care testing, here we are speaking about the lab investigations, which is done outside the main laboratory. Like, for example, using glucometers by nurses to check the blood glucose level for patients in inpatient wards. These kind of tests are done outside the lab, but according to standards, a supervision oversight from the lab should be there, making sure that these equipment or these devices are valid, and those who are using them are well trained, and there is a clear process and control for the whole issues related to the point of care testing. And there is point of care testing officer assigned by the lab from the lab technician, qualified lab technician, to do this supervision. Also, the quality management program inside the lab, to be participating in what we are calling the proficiency testing with other lab. And if we have a blood bank, here we have a lot of standards related to everything related to blood utilization, from donation, criteria to accept donors, how we are processing the blood, consent for blood donors, everything related to blood donation should be addressed in the policies of the blood bank and the blood bank transfusion standards. So it is covering both areas, donation and utilization of blood. And here also we have clear policies should cover all areas related to this part, like the release of the units, the release of, sometimes we are in urgent situation, we are releasing incompletely tested blood or blood components. So when we are doing this, under which circumstances, for example, the identification or discard of unacceptable blood, the process to prevent disease transmission by blood and platelet transfusion. So everything related to the blood bank, either in blood donation and blood transfusion, should be mentioned here in this chapter, and should be totally compliant with these standards, because these standards are also from the ESR, essential safety requirements. Then we have also the area related to the emergency release of uncross-matched or incompletely cross-matched blood units, how we are dealing with the adverse or suspected transfusion events, and how we are doing the analysis. Of course, all of these functions are supervised by the blood utilization committee in the hospital, which should be chaired by the medical director or one of his delegates. And here also, we have also some standards related to the pathology section inside the lab about how we are going to receive the specimens, how specimens are going to be performed, and how the results are interpreted by qualified pathologists, guidelines in dealing with the surgical pathology report, and how we are going to review the previous cytology or histology material and solving this pattern. So this is a quick overview for the lab chapter. Then we have the facility management and safety, the FMS, and the facility management. We have the facility safety, security, fire safety, emergency preparation plans, hazardous material, medical equipment, and utilities. All these areas covered in this one. So hospital leader established and support a facility management safety program covering all these areas: safety of the building, security inside the building, hazardous material and waste disposal, external emergency, internal emergency, fire safety, medical equipment, and utility system, and should be coordinated by qualified individual. And the most important also to have safety committee, which should meet on monthly basis, 10 meetings per year at least, and should supervise all issues related to safety inside the organization. Also complying to laws and regulation, all laws and regulation. We have also the warning and directive signs and the exit doors inside the hospital. Also the safety measures and equipment to be applied in relevant areas. Also how we are securing the patient and visitors and staff, hazardous material, waste management plan. All these should be covered inside this chapter through the policies related to this chapter. How we are being always prepared to deal with external disasters and internal disasters, and the fire safety standards. And all the fire safety standards, we have almost 4 standards. All of them are for essential safety requirements. And also there is standards and policies and procedures speaking about how we can manage and maintain the medical equipment in the organization, the training for safety, the utility management plan, handling of various types of medical gas and medical gas system. Also, it is clearly mentioned here in these standards in this chapter, and one of the also the ESR requirements, and the hospital unsafe handling and disposal for waste materials. So these are, I think, we took an overview for the whole chapters of CBAHI.
Oh, that was
So
great. Yeah, that was
yes,
great. And
we are trying to explain very huge voluminous standards in the shortest time.
And every chapter needs like 2 to 3 hours explanation, actually.
Yes. We are just mentioning highlights for the main issues inside each chapter.
And just wanted to inform everyone that Anexas conducts the CBAHI detailed program where you'll master all aspects and chapters and how to implement, etc. So those who are interested. So let me first conduct a poll before we proceed. And I just wanted to know, like, are you interested in a CBAHI full course? If interested, on which day you prefer to attend the session? So if you are interested, you can just answer this question and tell us the days, Fridays, Saturdays, or weekdays. Weekdays, it would be like in the evenings, to 2 hours. So Fridays and Saturdays, people are okay. So we have got almost 50-50 now. Okay, so I think, yeah, so almost 60% of the people want Saturdays and 40% on Friday. So no problems. We'll be, we'll send you the details. We'll compile a program and we'll send you the details. Those who have shown interest, we'll be sending you the details. Okay. And yes, just let us let us go ahead. Yeah, please go ahead.
Okay.
Yeah.
So, okay, before we starting to, is there any questions? Because I was moving
Yeah.
through the.
Yeah. So there are some questions, as I told already, that policies and procedures, who has to prepare. So that is one thing.
Usually, according to CBAHI, policy and procedure should be prepared by the process owner. For example, it is not acceptable for me in quality department to come and make the policies and procedures for those who are working in the OR. It should be prepared by the OR chief, by the OR head nurse themselves. And of course, in many policies and procedures, we are calling them multifunctional or multidisciplinary process. So even after being done by the process owner, but we should see involvement of the other departments who are related to this process in the form of a concurrent signature or meetings with them, so we can make sure that yes, the owner made the policy, process owner, but even in this process, it was multifunctional, it was multidisciplinary.
Okay. And also one question, I think one person had raised his hand. So would you like to
Okay.
write your question in the chat box? That will be great. I think I saw someone has raised the hand, but now he's lowered it. But if you'd like to just write your question in the chat box. Another question was for polyclinic. What does CBAHI recommend?
For polyclinic, as I said, they have issued a separate standard for ambulatory care centers and polyclinics. It was issued this year. They started to work on this one actually to visit centers this year. And it, of course, it is much more يعني less compared to the hospital standards because they don't have a lot of areas, a lot of issues like what we have in acute care hospitals. So they have separate standards, not this one.
Okay, and I also wanted that reminds me. We also have a AcroPro software, which can be used, which helps you to help in the journey of CBAHI. If time permits, maybe briefly, I will tell my team members to talk about it if time permits. Otherwise, we'll talk about AcroPro, the software which will help you in the whole journey at a later stage in some other program. So, and one more question was that as a healthcare manager, Saida is asking, or a quality control officer, how we can get accredited by Saudi Commission?
According to up to now, there is no clear designation or requirement or any clear specification for healthcare quality officer or healthcare quality manager or something like this. But for CBAHI, they are accepting according to your CV, according to your qualification, to come from any medical background, physician, nursing, dietitian, pharmacist, something like this. And then they can see that you have the experience and you have the qualifications or certificates in the field. This is for the CBAHI accreditation. Whenever they are coming to visit the quality department and they are asking to see the looking to the personal file and they are looking unclear how to be certified or to be recognized as a quality officer or as a quality director or manager.
Yeah, and I think Mahmoud Abdallah, I think he had raised his hands, but I'm not sure if you would like to write your question in the chat box. I think, or later on, maybe we'll make you the panelist. You can come on, you can unmute yourself also. But right now, if you can write in the chat box, we can answer your question. And
Okay.
And I think, yes, so yeah, please proceed. So,
Okay. So now just we finished the bulk of the main standards. We are coming now to speak about one of the specific features or characteristic features for CBAHI. They made what they are calling it in Arabic AMAN program or safety, and in English it is the ESR, essential safety requirements. So the essential safety requirements, the idea here, they selected certain standards from all the standards. We have almost 20 standards. They selected those 20 standards because they are associated with huge risk, immense risk for the organization or for the patients, and they considered these essential safety requirements, these standards as essential safety requirements. They must be there. They must be fully compliant in any organization. They will not accept anything in these 20 standards. Most of these standards, historically, they were adopted as essential safety requirements based on real incidents. For example, these standards, when it was 16 only, not 20. But after the big incident in one of the hospitals in the south of Saudi Arabia, fire, and maybe I think it exceeded 300 or 400 victims, something like this. It was one of the worst disasters in fire incidents in any hospital all over the world. After this one, it was in the south of Saudi Arabia, maybe 5 or 6 years ago. They took all the 4 standards of fire safety and they added to that. And in all of them, according to the CBAHI, they are selecting based on real incidents happened, and they took this as a countermeasure to prevent this from the future. So we have 20 standards, and the hospital must have them in place in full compliance, and they are scored by CBAHI as full compliant or zero. There is no partial compliance, full compliance or non-compliance. Partial compliance will not be acceptable for any ESR, and accreditation will not be granted for any hospital without having all the ERS are in full compliance. So if a hospital is, for example, all the standards are fully compliant, but one of the ESR is partially compliant or not compliant, regardless of the score, it will not pass the survey. This is the criticality of these standards. And to make it even more strict, although CBAHI is coming to visit the hospitals every 3 years in the normal survey visit for the full chapters and all standards, but they are coming on annual basis to do what they are calling the ESR survey. So if the hospital will receive today the full survey, so a full survey will come in 2025 after 3 years. But next year, 23, and next year after 24, they are going to receive smaller survey, shorter survey, only for these ESR requirements. So this is one of the main characteristic features for CBAHI compared to other kinds of accreditations available in healthcare. According to the 20 standards, as we said, we have 20. 14 of these standards are related to the patient care related areas like blood utilization, areas like related to the privilege of healthcare professionals, sedation and moderate sedation and deep sedation to patients. So 14 are coming from patient care related areas, and 6 standards are coming from the facility management related areas. We have the radiation safety program, we have the medical gas system, and we have the 4 standards related to the fire safety with all the requirements of the fire safety. And as we said, they are coming to visit you on annual basis to do the ESR survey. And for hospitals less than 200 beds, they are going to receive 1 surveyor for 1 day for the ESR. For hospitals which is exceeding 200 beds as a capacity, they are going to receive 1 day for the clinical and 1 day for the administrative or the facility safety standards by 2 surveyors. So these are the 20 chapters, 20 standards, and as we can see, one of them is related to the credentialing of staff providing patient care, how we are doing the primary source verification from the issuing university or issuing institute. The medical staff members to have clinical privilege and to be updated. everything related to blood and blood utilization of blood and blood products, the VTE, the deep venous thromboembolism prophylaxis for patient, the patient identification, the safe surgery by eliminating wrong patient, wrong site, wrong surgery, the anesthesia staff having the appropriate qualification, a qualified staff performing deep and moderate sedation, and the committee responsible for the infection control program. All these areas are and the isolation rooms and isolation practices inside the organization. So up till now, we are speaking about the 14 standards, patient care related standards. The hospital has a system for high alert medications, the localized sound-alike medications, and the hospital monitoring, identifying, and reporting the medication errors and the near misses and the hazardous conditions. And the blood bank develops a process to prevent disease transmission and blood or platelet transfusion. So these are the 14 standards related to patient care. For the facility management, we have one standard, as we said, it is related to the safety of radiology department. This is very important. The firearm system, then the fire suppression system, the fire exit, and the fire detectors and smoke detectors inside the organization. And the number 6 is related to the medical gas system. So these are the 6 standards related to the facility management. So this is the 20 standards related to CBAHI as ESR, essential safety requirements. Then we are coming to cover another area, which is how the accreditation policies are done. So the survey agenda, it is usually 3 days. The whole survey is coming for 3 days. And in the survey activities, we have a wide variety of activities done by the surveyor team. They are doing document review, they are interviewing staff members, they are doing tracers, different kind of tracers, patient tracers and system tracers. They are doing meetings with the committee members. They are doing medical record review, personal file review, facility tour from the bottom, from the roof of the building to the basement of the building. They are doing also additional survey activities according to their planning, and there is a briefing session every day about the findings and the plan of the day and the findings of the previous day. The survey team, in CBAHI, we have 2 parts. The core team, which is formed of 3 members, the medical surveyor, the nursing surveyor, quality and leadership surveyor. So these are the 3 surveyors moving inside the hospital, visiting all the areas inside the hospital, conducting tracers and meetings. But additional to them, we have a specialty team formed of 4 members. One of them is a pharmacist. So the whole survey, this pharmacist will be in the pharmacy related to medication only. They have another one, infection control specialist for infection control. They have laboratory specialist, and we have facility management and safety specialist. So we have the core team and we have the specialty team. For the scoring system, it is important here to know that even the final decision will be not given by the surveyor team on site. They are doing their report, they are giving you initial report, but they should submit the full report to the headquarters in Riyadh, and then after this it will be officially issued by them. In general, the overall score of the hospital is one of important factor. Other important factors that you have non-compliant standards related to the essential safety requirement, because regardless of the score, it will affect your final decision. And also, if they didn't find any what they are calling critical instance or scenarios while the survey is running on inside the hospital, like healthcare provider entering a contact isolation without wearing any PPE. For example, expired catheter being used in a patient. For example, newborn is not properly identified in the newborn unit. In these conditions, if happened during the survey, the surveyor team and the survey the team leader can can stop the survey and can hold the whole process, and it will affect the decision. In general, the scoring system, it is like this. We have 4 kinds of scoring for each measurable element and each standard. Not applicable if the standard is not applicable to the organization. And then we have 2, which is meaning satisfactory compliance or full compliance. If the compliance is 80% or more, then we have one, which is partial compliance if the compliance rate for this standard is 50 to 80%, and insufficient compliance 0 if the compliance is less than 50%. Then after counting all the scores for each element and for each standard, and the whole chapter will take the score, and then the whole chapter score of the whole hospital will counted by collecting all the scores of the all chapters. Not applicable chapters, like for example, I'm a hospital and I don't have a burn unit. So this means that the whole chapter will be not applicable, and all the standards of this chapter will be not applicable and will not be scored at all. So as we said here, we have this system for scoring, and we have more than 3,500 scorable substandards in the CBAHI. Then we are coming to the accreditation decision, and the accreditation decision is coming into 4 areas: accredited, conditional accreditation, preliminary denial of accreditation, and denial of accreditation. Accredited, if the hospital overall score is above 85, all essential safety requirements are fully compliant, fully met, and there is no other issues or concerns for the surveyor team, then we have the status of being accredited. Conditional accreditation, overall score 57% or above, but less than 85. Some of the essential safety requirements, less than 25% of them is not in a satisfactory compliance status. Preliminary accreditation, denial of accreditation, here we have presence of an immediate threat to safety of patient or visitors or staff observed by CBAHI surveyors during the visit. Significant non-compliance with the accreditation standards at the time of survey. Failure to timely submission of the post-survey requirements. If you are receiving your comments and there are certain requirements to do a root cause analysis or action plan for certain issues, you have certain time frame and you should respond within this time frame. The hospital has received the conditional accreditation and was subjected for follow-up survey, and they were not able to pass the follow-up survey. Here they are going to the preliminary denial of accreditation. Or if the hospital is going to refuse to receive the survey team or to expose everything to the survey team, or providing fake documents or something like this, so it will put the hospital at risk for denial of accreditation. Denial of accreditation, as we said, if the score is less than 75 or if more than 25 of the essential safety requirements are not in satisfactory compliance. So these are the 4 kinds of decisions which can be taken after the survey. Accreditation maintenance, which is the post-survey requirements after the hospital received the survey team and they finish the visit and they return back. Some requirements are required from the hospital. What is these requirements? We have the corrective action plan. When accreditation is awarded to the hospital, they are receiving the full report, and certain standards, it is required for them to provide a corrective action plan, complete corrective action plan, to be submitted to CBAHI, to be reviewed by CBAHI and accepted by them to issue the final decision. And the time frame here is 120 days, 4 months almost. A delay in submission, the corrective action plan, more than 30 days by the time frame, the due date, without any justification, might result in temporary suspension of the accreditation certificate. So the accreditation certificate, even if you are accredited, will not be issued officially except after all the standards requiring corrective action plan will be addressed, and these corrective action plans will be submitted and accepted by CBAHI. So also the standard compliance progress report, when the hospital is conditionally accredited, here the time frame for them is less, not 120 days, but it is within 60 days. And they are, after this, they are liable in this status who are conditionally accredited to have a follow-up survey within 30 days after submitting their standard compliance progress report, 30 days, just to make sure that they are really implementing these corrective actions. Also, what also is required from me as a hospital, we have also the midterm self-assessment. We said that the accreditation period is every 3 years. So we, after within 15 to 18 months in the mid-cycle, in the mid term of the whole accreditation period, the hospital is required to do self-assessment according to CBAHI standards and to submit all the assessment in the CBAHI portal, in the CBAHI website. So you are giving all, you are, for example, assigning 7 surveyors from your team inside the hospital, and they are doing the same like the real surveys. They are doing all the activities and they are doing their assessment for everything, and their reports are submitted through CBAHI portal within 15 to 18 months from the survey date. So this to be reviewed by CBAHI and to be accepted in CBAHI. If you are delayed more than 2 months from submitting it, it will also make the hospital liable to face temporary suspension of the accreditation. In general, also, before CBAHI survey coming to visit you, you are going to submit to them or to prepare to them a lot of required documents so they can review before coming to your hospital. Like what? The high-level organizational chart, the list of board directors, the governing body, the job type, the hierarchy of the main departments and the organizational chart, the list for all contracted services and who are responsible to supervise them, the accurate list of patients currently in the first day, currently receiving care inside the hospital. In the first day, the list of operative and invasive procedures scheduled in this day in the hospital. You are going to give them the top 5 diagnoses, the top 5 procedure performed, a list of all the improvement projects done in the track period of the organization, the clinical practice guidelines you have inside the organization, the risk assessment, including the failure mode and effect analysis and the hazard vulnerability analysis done by the organization, a copy of comprehensive systematic analysis for root cause analysis conducted inside the hospitalization, also the required policies and procedure according to the CBAHI guideline. In each chapter, they are requiring certain documents by name. So you will review the list and you will prepare and submit these policies and procedures and programs and the plans mentioned by name. Also, all the committees, the terms of reference of the committees and sample from the minutes of meeting, the strategic and improvement plan of previous surveys to be available, and current map of the hospital, and the all medical record forms utilized in your medical record. In this, at the opening conference, it is done in the first day. The main idea is to do introductory for the survey team and survey process and agenda. And from the other side, they are listening to the hospital. You are going to give them a brief overview about the hospital scope, the hospital services, the outsourced contracts, any points related to the hospital information, and clarify any points related to the survey agenda. Okay. And then they have also the facility tour. These are the main activities inside the CBAHI. Facility tour, it is done by the surveyor assigned from CBAHI with the team inside the hospital, and they are visiting all the hospital. And in this one, they are aiming to make sure about that all the components of the program, the 8 program components, are well implemented and well applied inside the organization. We have medical record review session, and in this medical record review, each surveyor will select 10 medical records at least based on his list, and then he will review the medical records. Medical and nursing surveyors are the one responsible for this one, and they are going through the closed patient medical record review to ensure that the medical documentation according to standards, the standard related to medical care is strictly followed in the right way, and the tracking period will be 12 months. So if they are visiting you, for example, in December, they can ask for files from last December. They have 12-month tracking period to go and check. Then we have the personal review session. The personal review session, it is done by the 3 core team: medical, nursing, quality. Medical is going to audit physician files. Nursing is going to audit nursing files, and quality will audit the administrative and safety personnel. And in this one, you are going to check the with the human resource help, of course, department, the content of the personal file. You are going to check the job description, issues like the annual evaluation, the qualifications, the certificates, all these issues which should be present in the personal file of the staff. They have a checklist and they are trying to make sure that all these documents are present and updated and valid in the file. So I think we covered in brief whatever we were able to cover related to CBAHI, and then I am waiting for comments and questions.
Yeah, so we've got one question here from Mahmoud Abdullah. In case of using special vans to collect blood from donors, such as in secondary school or university, is CBAHI having some guidelines and procedures?
You mean that you are going there to do the donation there, or they are
Yes,
coming to your premises
collecting
to
the
do the
blood
donation?
from, yeah, they're collecting the blood from the from the donors, such as in secondary school or universities.
For campaigns outside the organization, CBAHI is not speaking about this one. They are speaking about donation running inside your premises.
Great.
But they will check if you are even doing the donation, you are taking the donation from outside, and you are bringing the blood bags to your premises, then these blood bags should follow the whole process in your policy for labeling, processing, detecting any infection, storing, everything will be followed, strictly followed. But for the donation activity itself, it will be beyond the scope of CBAHI.
Great, great. And also we have got, actually, as I was talking about AcriPro, which helps, this software actually helps you in implementing CBAHI. So this, just briefly, maybe one of my team members, Naveen, if we can take 5 minutes to explain this before we proceed further.
Hi everyone, this is our AcriPro software. So this software helps in getting the accreditation. So basically this is a super client admin, which is considered as the main branch of the hospital. So wherein the super client admin or the head branch can create its multiple branches. Let's say this particular super client admin has two particular branches under this hospital, branch 1 and branch 2. So all its individual courses or its individual chapter wise course or the compliance med scores or the library scores or the chapter substandard scores can be measured. If the particular branch has 3 updaters, all the updater scores can be viewed under a single window. So updaters are the users who are responsible to do all the activities in getting the accreditation process. Similar way, all the checklist scores, all the checklist activities, the ESR scores and the non-ESR scores. Similarly, if there's any KPI values can be measured. So similar way, we have loaded the system with CBAHI, JCI and ISO 9000. So under every chapter, there'll be a list of standards like DA, dental, leadership and provision of care. So under DA, we have 4 standards. So for every standards, there'll be a list of substandards, and for every substandards, there'll be a set of activities. If at all the hospital feels that these particular activities are not sufficient, the hospital can add its own custom activities. It could be a checklist activity, or it could be a data collection activity, which involves a KPI or a non-KPI, which is an observation activity, or the document evidence. They can set a frequency value on how frequently the activity should be done, and it can assign a submission date. If it's a weekly activity, every week of that particular day, the activity should be met. Coming to the scores, let's consider this particular hospital has 3 updaters. So all the updater scores with its particular assigned activities or the libraries can be viewed. Similar way, if we have any internal surveyors, we can view the scores. Internal surveyors are the people who surveys the scores or the activities done by the updaters. So under managed surveys, the super client admin can create its own surveyors, whether it could be the internal surveyor or the external surveyor. If it's an external surveyor, we specify the date and time on when the survey should be done. Then comes the reports. So under reports, all the activities and other scores can be viewed. The client admin can view if the status is done or is it a pending activities. So all the updater reports or the checklist scores. So if we consider here, these particular activities are pending by the updater. So the particular updater name will be shown, and even for which library it is assigned can also be viewed. So once all the activities are done, the status changes from pending to completed. Similar way for document evidence, all the list of document evidence activities which are assigned to that particular hospital will be shown. The same way the KPI reports. So the KPI reports can be compared between all the months. Let's say for the October month, the activity is completed. So the actual score and the submitted score can be measured. Similar way for the observation activity.
Yeah, so I think thanks for giving a nice overview. I think those who are interested in learning more about ECRIPRO software application, we'll be happy to present in detail for your own clinic, for your clinic or polyclinic or hospital. If you are interested, just let us know and we'll conduct a special program for your clinic or polyclinic. And we'll give you all the details and we'll be happy to answer your questions. So, yeah, thanks, Naveen. So, now coming back to Dr. Radwan. So, I would like to thank Dr. Radwan for doing giving a very nice overview about CBAHI. And personally, I learned a lot also because although I have been part of ECRIPRO Foundation team, founders team, and I have got a fairly good idea about CBAHI, but not in so much of detail. So thanks for that, for talking about it. And as usual, we always like to hear from our own certified professionals. And good to see one of the certified professional from Anexas talking about quality related topic. And we also encourage everyone else, those who want to speak about any quality related topics, feel free to connect with us, and of course we'll be happy to give you. So a lot of people are telling excellent lecture. Saida Naz is telling excellent lecture. Thanks, Saida. And I hope and Hiba is also telling so thanks a lot, and we will be in touch with you. Everyone will receive our receive our the survey form, and all the, if you are interested in our training program, we'll be happy to have you there. So thanks a lot, Dr. Mahmood Radwan.
Dr. Mitab, just because Dr. Mitab, because I went, I think someone was asking about the antibiogram. Antibiogram, just to be aware, it is a map or according to data, according to results from the lab and from the areas. They are infection control with the help of laboratory in hospitals. They are drawing a map which antibiotics is more effective in this organization, which organisms are present in the organization, and the sensitivity to different kind of antibiotics. So you can utilize the antibiotics in the proper way, and you can avoid the resistance to antibiotics. So this is the antibiogram in just a brief. Yeah. And again, it's my pleasure to be introduced in a session by you. This is very, very, for me, it's very, very good moment. Thank you very much.
Thanks a lot. Thanks, everyone. And once again, those who have not shown interest, if you would like to, just let us know about your interest, and we'll be happy to send you all the details. We'll be conducting a CBAHI training program, full-fledged training program. We will be explaining the chapters in detail, and so we'll get in touch with everyone about it. Thanks a lot. Thank you.
Thank you. Thank you.
Okay, some of you are asking polyclinic also. We like to have a program. Okay, we'll do that. I think my team can find the experts, and definitely we'll be happy. We'll be happy to give you all the details of polyclinic. Great. Okay, so stay in touch with us. You can like our Facebook page, Instagram page, Anexas Europe, and also LinkedIn page, Anexas Europe. Please like it. And a lot of people I see are already linked with me on LinkedIn. So if you want personally, also you can link with me. Amitabh Saxena is my profile account, and I keep sharing a lot of quality related topics. And also LinkedIn Live, we invite a lot of experts from various fields in quality, especially healthcare quality, where they present about lots of upcoming updated topics, etc. So thanks a lot, and see you soon. See you soon. We also conduct Lean Six Sigma training, CPHQ training, PMP, project management training. And if you are interested in any of these programs, let us know.